Okay, so the first specimen is a ascites specimen. The patient had a history of pancreatic cancer. 可以吗？再来一次，好。Okay. So the patient had a history of pancreatic cancer. So in this specimen, we have a lot of tumor cells. So you can see these cluster of tumor cells, and because it's a pancreatic cancer, so it's very common to see this tubular structure or a very tight, small tubule, small glandular cells cluster. And at the in the cytoplasm, oftentimes you can see some oranginophilic staining material, which suggests it is mucin. So we have a little bit of mucin over here. So this is compatible with pancreatic cancer with peritoneum spreading. So if you take a look at the cell block preparation, you can see a lot of tumor cells. So oftentimes for the pancreatic adenocarcinoma, the size of the nucleus would be smaller than what we most commonly see for the lung cancer. It would be a large nucleus, but oftentimes for the pancreas cancer, it's small, and the cytoplasm could be abundant, clearing, and some with apparent mucin. So this is very typical for pancreatic cancer. The second specimen is also from ascites. So in the background of this specimen, you can see there were quite abundant mucinous-like material in the background. So this is not a common, like a normal ascites specimen, because in the normal ascites specimen, you won't see this kind of background. And here we see a very bizarre cell. Next to the cell, there is one lymphocyte. But you can see this cell, the nucleus is very, very big. It's very, very atypical. So we know this is positive. So this is a malignant cells. And here we also see another cell looks very strange and with an eccentric nucleus. The patient had a past history of colon cancer. So in this specimen, the tumor cell is quite scant. But indeed, we see abnormal extracellular material, looks like mucin, and we see like this single, very high-grade, poorly differentiated cell. So this is positive for adenocarcinoma. And it can be compatible with the patient's past history of colon cancer. So again, another ascites specimen. And in this specimen, the background, we see a lot of inflammatory cells. We have histiocyte, we have lymphocyte, maybe a little bit of mesothelial cell, like over here. And from here to there, we can see very scant, but definitely like bizarre-looking malignant cells. So in this cell, we have a single cell with two nucleus. And you can see it is hyperchromatic. The size is markedly enlarged, and the nuclear contour is very irregular. So this is positive. And the patient had a past history of pancreatic cancer. So rarely the pancreatic cancer can present with a very poorly differentiated morphology. And in this specimen, the tumor cell is very scant. So we only see a few. Here is one cluster. This is three-dimensional, and you can see luminal border at the edge. And it is very like you need to focus up and down to see clear. So this is also positive cluster. And at the edges, you can also appreciate there might be a little bit of mucin in the cytoplasm over here. So this is compatible with pancreatic cancer. The next specimen is quite unusual. This is from a 78-year-old male with pleura effusion. So in this pleura infusion specimen, we have some normal component, some inflammatory cells, lymphocyte, histiocyte. Maybe this is mesothelial cells. This is histiocyte. So we see some normal element. But here we start to see some loosely cohesive cells with very irregular nuclear contour and hyperchromatic, like a chromatin pattern. And here as well, and you can see this is also a loosely clustered without like a very apparent cellular arrangement. It's just a flattened sheet, but it doesn't have the like a sharp edge as what we see in the epithelial like a tumor. So this is a loosely cohesive cell, and the cytoplasm is relatively abundant. If you pay attention to the chromatin pattern, this is what we would think salt and pepper pattern. So the chromatin, you can still see granularity. It is like a little bit coarse, but not that coarse, and it is very like a equally distributed, like a diffusely throughout the entire nucleus. It is not like clumps here and there with irregular pattern. It's very homogeneous. So this is a typical salt and pepper pattern. So you will see these like a core black pepper, and in between the black pepper powder there would be like an empty space. It suggests it's more like salt. So this looks like a neuroendocrine feature. However, the cytoplasm is a little bit more than what we would expect it. The patient had a past history of Merkel cell carcinoma, which is a neuroendocrine carcinoma arising from the skin, primary skin neuroendocrine carcinoma. And the typical morphology would be similar to small cell, but in these specimen, I would say the cytoplasm is a little bit more than usual, but the cells still have definite neuroendocrine, like a chromatin pattern. So this is positive for carcinoma, and it can be compatible with the patient's past history of Merkel cell carcinoma. So the next specimen is also unusual. It is a 68-year-old female with pleura effusion. She had a past history of primary lung adenocarcinoma, biopsy proven, and it was diagnosed like 6 months before this specimen. So this is a pleura effusion specimen. So you can appreciate some similarity between this specimen and the prior specimen, that the nuclear chromatin pattern is very homogeneous, and the cytoplasm in this specimen is much scant. So it doesn't have the typical adenocarcinoma cytomorphologic feature, which is vesicular chromatin, prominent nuclei, and the 3-dimensional cell cluster. But here you didn't see that. So it looks like a small cell carcinoma. Small cell carcinoma in the effusion specimen can be easily missed. So you need to pay attention to these like very hyperchromatic feature on the low power. And if you go to high power, you need to differentiate the homogeneous salt and pepper type chromatin pattern than comparing to the normal cells. So I would say in this specimen, the lesional cell is very, very scant. But most of them have these very homogeneous nuclear feature. And in this single cell, it is a little bit different from the other because it has an eccentric nucleus. So here still seems to be like a adenocarcinoma, but it's much scant than the other, like a small cell carcinoma component. So if we take a look of the cell block preparation, we know the tumor cell is very scant, but here you can definitely still see the small cell carcinoma component, and you will see the classic arrangement, which is molding. So you see cellular molding over here in this very small cluster. This is small cell carcinoma. So in patient with primary lung adenocarcinoma who receive like a kinase treatment, and if the cancer develop like drug resistant, there were a couple mechanisms. You can acquire a different mutation, a drug resistant mutation, or you can do transdifferentiation into either small cell carcinoma or squamous cell carcinoma to develop the drug resistant and to have progressive disease. So indeed, the patient, after only 6 months treatment, she already developed progressive disease. And in this cluster, this looks more like adenocarcinoma because we have more cytoplasm. But in the other foci, it is definitely small cell carcinoma, right? So it is very important that we need to inform the clinician that the tumor has already developed small cell transdifferentiation. So the TKI would be no response, and they need to shift to the chemotherapy regimen for the small cell carcinoma. Okay, this is a new patient. This is pleura effusion. So this is what we would most commonly see for primary lung adenocarcinoma, which is the most common, the top like cancer in Taiwan. And we can see this is typical glandular like structure, and what we need to pay attention is to this typical nuclear feature. The chromatin is very like pale, sometimes you can see small bubbles, so we call it vesicular, and the nucleus is usually very prominent. So this is typical. So here, these ones you can see typical vesicular chromatin pattern and the prominent nucleoli, and in 3-dimensional cluster, and this is typical morphology for adenocarcinoma, and which is different from the small cell carcinoma. So let's take a look again for the small cell carcinoma. So you see, this is homogeneous, and you can see like a granularity of the chromatin. So this is small cell carcinoma. So this is very different. So it is not very common to see small cell to see adenocarcinoma with small cell transdifferentiation, but this is a case. So the next case is parotid aspiration. The patient is a 73-year-old male, and from the requisition sheet, you can see he is a smoker for a long time. So in this liquid-based preparation, what we have seen, these cell cluster, they are all histiocyte, right? So the histiocyte is easy to recognize by the texture of the cytoplasm. You can see a lot of bubble because he is eating all the material and put it inside the cytoplasm. So these are all histiocyte. So we only see histiocyte and the background granular debris, right? We didn't see any epithelial cell. However, the feature of these cystic component, these granular, very granular, like a cellular debris, is very, very typical for the cyst content of a Warthin tumor. And here we have one cluster of spindling cells. It looks a little bit, I'm not so sure, but it could be epithelial cell. But if it is epithelial cell, it would be like a squamous cell with squamous differentiation, right? So here we have a cluster, a very small cluster of squamous looking cells. And here I'm not so sure if this is it looks more like a multinucleated giant cell than the epithelial cell. So this is what we have. What we have only mostly cystic component and one cluster of squamous looking cells. And this is the direct smear. In the direct smear, you can see more like a liquid component in the background. And all of these cellular components are histiocyte. So what would be the most appropriate diagnosis? So originally, it was interpreted as AUS, which is a good diagnosis. So in a non-mucinous cystic aspirate, and if you see some cellular changes, make you worry about, like here, make you worry about metaplastic change or similar changes, you call it AUS, which is very reasonable. But because in our experience, it is most commonly to be a Warthin tumor and likely to have a squamous metaplasia in this setting, so we would do a cell block from the residual liquid base like a specimen. So in this cell block, you can appreciate here is lymphocytic stroma. So you get the stroma now, not only the cyst content. And also we see a small cluster of typical bilayer oncocytic epithelial cell. And the clinical presentation is also very good for Warthin tumor. It is an older male, and he has a long history of smoking. So because of the cell block preparation, we change our diagnosis from AUS to benign. So it is a benign neoplasm, and it is a Warthin tumor. So this is the application of cell block preparation. The next specimen is also from parotid gland, and we are very familiar with this tumor now. So it is a very cellular aspirate, and you see cellular cluster as well as single cells in the background. And most of the cells have this oval nuclear feature, and it's very small and very regular. In addition, you can see some like extracellular material with this grayish, bluish staining and with very fibrillary edges. So this is typical for polymorphic adenoma. And in this area, we can also see the ductal component. So you can see beautiful luminal border formation. So this is definitely ductal. This is not my epithelial cell. So for the for the polymorphic adenoma, we would like to see mostly myoepithelial cell. So most of the cells are myoepithelial here, and we would also like to see extracellular stroma. And sometimes we can also see the ductal component. So with these three components, this is perfect for polymorphic adenoma. However, we still need to check if there is no like a typical cell, and in this specimen there is none. So we call this a benign polymorphic adenoma. The next specimen is from a neck lymph node. So in the neck lymph node, for the benign cases, you would expect to see a lot of lymphocytes. But in this specimen, on low power, we already see a lot of very three-dimensional architecture and with prominent papillary formation, right? It looks like branches of the tree or something like that. So this is a highly cellular epithelial, like aspiration coming from a lymph node. So it is metastatic lymph node with carcinoma. The patient had a small, very small tumor in the thyroid, but it has microcalcification. The lymph node is actually bigger than the foci of the thyroid. So they decided to aspirate the thyroid first, and indeed, it showed typical nuclear and architecture pattern for papillary thyroid carcinoma. So for this case, we will call it positive carcinoma compatible with metastatic papillary thyroid carcinoma. So for the papillary architecture, so here is another direct smear of thyroid aspiration. In this aspiration, you can see they are also very like a three-dimensional like architecture with like a fibrovascular core in between, suggests it's a papillary like a growth lesion. But for the papillary pattern, we still need to go to high power to check if the nuclear feature is typical for papillary thyroid carcinoma. In this specimen, all these like a cellular component has very bland looking rounded nuclear and with like a discernible granularity of the chromatin. So these are all benign follicular cell. For the follicular nodular disease, we used to call it nodular goiter. They are commonly with structure that we would call papillary hyperplasia. So this is a typical case for nodular goiter with papillary hyperplasia. You can definitely see very prominent papillary growth pattern. But don't rush to the diagnosis of PTC. You still need to go to high power to check that the nuclear feature over here doesn't fit the diagnostic criteria for PTC. These are all benign follicular cells. So we call this specimen category 2, benign. So not all papillary architectures are malignant. And this is the loose stem preparation. For the loose stem preparation, I would say the interpretation is more difficult because it doesn't show the chromatin pattern that clearly. Sometimes you will see some artifactual, like a small dot in the nucleus, make you wondering if it's pseudo inclusion. So sometimes it's not very easy if you only have the loose stem preparation. Sometimes it's not really easy. Okay, so let's move to the pap smear. So yesterday I told everyone that you need to pay attention to endocervical components. So today our screener wrote a lot of no endocervical component. However, you still need to pay attention to the requisition sheet, the clinical information. This patient already received hysterectomy, so definitely they won't be endocervical component. You need to like pay attention to that. So this specimen has been noted by our screener as low CO specimen. However, I only find like one cell that can be qualified as low CO, and actually it is not very hyperchromatic, and the contour of the coilocytic change is not very sharp, and there's only one cell. The other is it doesn't fit the criteria, so I changed the diagnosis to atypical squamous cell. The patient had a past history of low CO and proven by colposcopy, and she received total hysterectomy because she has already passed like a menopause, and she's an elder female, and she feel like to have the uterus removed. So we only have a typical squamous cell here. So the other atypical squamous cell is also similar. We have only a few cells that will be qualified. So these are most likely squamous metaplasia. These are metaplastic cells. But here in this metaplastic cell, we have a little bit irregular of nucleus and enlargement. So I think this is okay for a typical squamous cell. And the other dots doesn't fit the, and probably not squamous cell, maybe glandular cell or the other different cell type. And here is also immature squamous metaplasia. So we have a few like a typical immature squamous metaplastic cell, some with binucleation. So the best we can give is a typical squamous cell, and it is not qualified for low CO. And finally, there were two interesting cases. This case I forgot to show everyone. I think the day we have too many positive cases, so I skipped this one. This is also a pap smear. On low power, they were like a mostly single cell, and you can see a lot of very hyperchromatic cell in the background, right? So let's make comparison. We have this is a benign intermediate cell. This is benign intermediate cell. And here we have a very hyperchromatic and a very the nuclear and cytoplasmic ratio is very high. There's only very scant cytoplasm. So here it looks like a high CO. This looks like a high CO, right? However, if you go to these cells, what do you see? So we have some pigment in the cytoplasm, and it is very dark staining. So this is a melanoma. This is not a high CO. This is a primary melanoma from the vagina mucosa. So here you also have these malignant cell with pigment. And for the melanoma, it is quite common that you will see prominent nucleoli in the cells. So melanoma is a great mimicker. It can mimic any like a histiotype. It can mimic adeno, it can mimic squamous, it can mimic small cell, it can mimic everything. And in this case, we are lucky that because it is a melanocytic melanoma, so we can easily identify there are melanin pigment in the cytoplasm. Sometimes the pigment will be inside the histiocyte. So this is more likely a histiocyte because the nucleus looks benign and the cytoplasm is plenty. So we call this melanophage. And here is some pigment over here. But this looks like a malignant cell with a very angulated nucleus and very high NC ratio. So this is positive cell for melanoma. So you need to make distinction between melanophage and the real tumor cell. So this is a primary melanoma of vagina, and you can see the positive cell is throughout the entire smear. So this is also very uncommon to see. Okay. In the last case, the patient had a past history of endometrial adenocarcinoma, and she has received radical surgery 10 years ago, 2014. So the patient has been followed regularly, and she had recurrence, I think, couple years before, and this would be the second time of the recurrence. So here, you can see this is with adeno feature, right? So you have prominent nucleoli, vesicular chromatin, glandular arrangement. So this is adenocarcinoma. This is not squamous cell carcinoma. And the cytoplasm is more loose and more bubbly. So this is recurrent adenocarcinoma. And here's also one cluster, and this is also positive adenocarcinoma. Okay, so this is for all the cases today.